made sense. The nanas. Yeah. Okay, because you do jump. So the conclusion with this physical assessment tool, this one, okay, is that even though I indicate the neurological, the systems in isolation, none of these systems can really be assessed in isolation because they overlap during your observation and your assessment. Okay, but the important thing to remember is that we started at the head of the baby, which is on top, and that fits in under the neurological system. And then we assess the fontanelles, anterior and posterior, and we also feel for the skull bones and overlapping of the skull bones, as well as the sutures. And also you need to determine on the scalp, the head of the baby, if there's any edema or bleeding from a difficult birth. Okay, and then please remember that when you do a head circumference, that that measurement fills and fits in under the neurological system, but you don't do the head circumference during your physical assessment, although you can if you are a skilled assessor. Otherwise you can do the measurement of height, head circumference and weight at the end of your physical assessment, which is an easier way for most people to do. Okay, then the next, when I was still at the head area of the baby, I started looking at the baby's senses. So I assessed the baby's eyes. I looked for bilateral position. I looked at the eyelids. If the baby's eyes are open, I look at the iris, the eyeball, and I look at any discoloration or discharge, and I look at the pupil size and reaction. And I used my environment to my benefit, but I still protected the baby from the bright lights. However, I used the bright light to see if the baby is giving reaction on the eyes when I expose the baby to the light, but don't expose the baby to the light the whole time. Then I looked at the baby's ears, looked for position, looked for low set or high set ears, looked at bilateral shape, look for patent ears, look for any discharges, and see if there's any attachment on the ears. Attachment on the ears can give an indication of a kidney problem. Okay, then I looked at the baby's nose. It wasn't necessary to palpate the baby's nose because babies don't like to be touched on their nostrils, because any touch that's on the front of their face gives them a reflex and they react to that. So my goal during the observation and the assessment is to keep the baby as calm as possible in order to do a proper physical assessment. Then so I looked at the nostrils, are both patent, and here I used mainly my ears to listen for abnormal breathing. I looked at nasal flaring, which is an early indication of respiratory distress, and then I would note any abnormalities. Regarding the mouth, and that I know I didn't assess, so I'm correcting it now. What you could have done was, or me could have done, and I actually touched the baby's cheeks, but I interrupted my own thoughts, was when you touch the baby's cheeks like this, you look and see if the baby turns his head towards where you touched the cheek, okay? Because the baby will demonstrate a rooting, opening the mouth and sucking reflex. So that's part of the mouth assessment. I would have also, and that is what I omitted doing in my recording, so we must one day do a nice recording on this. With the mouth, I will look at the lips to see if the lips are moist or are they dry, because that's an indication of dehydration or hydration. If the baby opens his mouth, yawn, sticks out his tongue, I look at that. Some people like to put their finger in the baby's mouth to feel for a cleft palate or a cleft palate, and I don't necessarily do it. There's warning signs that will show you that there's problems. If the mother tells you that the baby chokes with every feed, then you can think that. So I don't necessarily put my finger in the baby's mouth. If you do, please wear gloves, clean gloves, okay? And then look at the shape of the tongue. Does the baby have an abnormally large tongue or an abnormally small tongue? And look at the color of the tongue, because it's part of the central color of the baby. Then I look at the skin. look at the skin turgor. So I did touch the skin and I observed the skin, and every time you touch the baby you see and look at the skin, look at the rashes, and look at the color of the baby. Is there any cyanosis? Is there any paleness? Or is it a nice pink skin tone? Especially when you do the capillary refill, you look at the nail beds and you look at the inside of the palms and of the soles of the feet to also see for a capillary refill and a pink skin tone, because it indicates good saturation. Then cardiologic system, that is when I used my stethoscope to listen to the heart rate. Normal heart rate for a newborn baby is about 120 to 150 beats per minute. And then, like I said, you do the capillary refill. If you would have been in an ICU, you would have done a blood pressure, but you are not. So this is more than enough, as long as these measurements are within normal rate. Then next, and that happens very quickly, that you follow and you go to the respiratory system, and it would have already started when you would have done the senses assessment and even the neurological system, because you look at the way the baby is breathing. Again, you use your stethoscope. I taught you that you will use upper right and compare with upper left, lower left and upper and lower right, and you compare for any sound, breathing sound. You listen for air entry. How does it compare bilaterally? Does the baby have wheezing? Does he have crepitation? Is there any sternal recession and any intercostal retraction? But this is very easy to note already quickly, just by already before undressing the baby. You would have seen respiratory distress because the baby would have had nasal flaring, and you would have seen fast breathing. Normal breathing rate for a baby is about 20 to 40, around there. And then I went down and I then assessed the gastrointestinal tract. I look at the abdominal shape, which I didn't say, but I did do that. Look at the distended abdomen or not. When an abdomen looks like a drum and it sounds like a drum, it's a distended tummy. And the babies usually grunt when there's a distended tummy as well. So they make the sound, okay, that's an ill baby. Find out at that stage what is the baby feeding. But this you would have also already have started when you did your physical history taking. But sometimes the mothers hide information, so they might not tell you. They might tell you that the baby is exclusively breastfeeding. They know the word very well, exclusive breastfeeding, but they don't practice it, and we cannot judge them. We rather have to do health education. So I want to say, if a baby has a distended tummy and grunting, and it's not lungs, but there's grunting because of the distended tummy, this baby is very probably not exclusively breastfeeding. Something else is going on, and you need to build a trust relationship. Okay. And then at this stage, so ask about the different feeds. Find out, maybe they started solids, and don't attack her because they shy away and they do more harm. Also at this stage, check or ask for stools. Now my baby that I assess now had a clean dry nappy. Okay. But usually at this point, you can see if there was stools, what is the color, what is the fragrance, smell of the stools. Is it offensive? Is there any blood? Is there mucus? What is the color? That can also indicate to you what the baby is being fed. Is the baby constipated? A baby that is constipated has passes little stones of stools, or do they have diarrhea? Diarrhea is watery stools. It actually absorbs into the nappy, and that is what diarrhea is. Normal stools for a baby is usually the texture of toothpaste or yogurt, and it's usually green or yellow. Okay, so then from there, so I quickly flowed over to the following, and also all of these observations were made. I just didn't mention it to you, okay, because it's quite difficult, sorry. Then I do the GUT, genitourinary tract, and that at that stage you determine what is the gender of the baby. Some babies have both genders, and then you need to get history and refer, because that causes lots of emotional problems also later on. So you have to refer such a baby to a pediatrician and a social worker and all of that. Are the genitals normal? Is the baby passing urine? And you can ask the parents. And while you change the nappy or take off the nappy, smell, and just it will come up. You will smell if it's an offensive smell or not. Babies that are dehydrated have very strong urine. You can smell that. So that's why I say use your. Then endocrine system. Now this is interesting, and the question was there yesterday. So I do the baby's body temperature. I take the temperature at this stage. Okay, maybe do it in the beginning of your assessment. If your room is nice and warm and comfortable, the baby won't lose temperature. So doing it when I did it was also fine. But now this room is cold, so our baby would have been cold. Okay, then blood glucose. There was a question in the class yesterday. No, I'm not going to do a routine HGT on every baby. If you do one, you do it with doing a prick on the heel. So there on the side of the foot, one prick, and you use your HGT machine. But you don't do it as a routine. It's expensive and it's invasive. Yeah. The only time when you will do a blood sugar monitoring is when the baby's body temperature is subnormal. What is a subnormal body temperature? Less than 36.5. Okay. Then you do a blood sugar, because that will then lead to hypoglycemia. Or if the baby is underweight and has tremors, then it could also be an indication for you to do a HGT. Okay, and please record.
Are we talking about in a clinical setting or anywhere?
I'm talking of a clinic setting.
Clinic setting.
But you can apply this anywhere. You can apply this to, if you are referring to hospital, postnatal.
Because I'm looking at any MOU level where you have to deliver a baby, because most babies that are born smaller or bigger, they have to be done HGT.
Very true. Yeah. But this is for the context of a clinic. Yeah. But your question is very good. Just park that. We'll discuss it outside of the video. Then, and this also happened very quickly, and it was almost melted into the next section. Musculoskeletal system. You can see when I did the physical assessment of the baby that I tested musculoskeletal systems. So it's almost a natural move from the one system to the following, but they are interlinked. So look at bilateral shape. Look at any abnormal movement or limbs. Maybe the baby has an extra finger, extra pinky, or an extra toe. Okay. Is there any signs of fractures? Fractures can happen in the the collarbone after a difficult birth, or babies develop fractures on the hip or on the femur, and that usually is visible when that limb is immobile and has an abnormal shape. And then assess for hypo or hypertonic. So a hypotonic is a lethargic baby, and that's usually hypoglycemic babies. And hypertonic is when you can't open that baby's arms or legs, and they are flexed a lot, and the baby just feels tight and solid. And that is an early indication of a neurological injury. And it is your task to refer and to record and refer to someone senior to you. Okay. Then number 9. So that's why I ended my physical assessment, because now I want the baby. Okay. But in my GOBI FFF, and now still I can ask the mother, but now I've dressed my baby, and now this is why I'm doing this now. Part of your assessment is finding out about medication. And you casually just ask, no judgment, because the mothers they are stigmatized. Mommy, what medication are you using? What medication are you giving your baby? And don't just rely on the caregiver, the adult who brought the baby. Look at the Road to Health booklet and see what is written there. Importance is that we want them to continue with their medication. Doesn't matter the diagnosis, we want them to continue, and they must be health educated properly. And then number 10, development, that the GOBI FFF. So have a look and see what is the baby's development, but also his growth. So let's just quickly look at the development here. It must be age appropriate. So a newborn baby will not have good neck control, but a 6-week-old baby will have good neck control. So you need to know the development milestones that each baby has to have at that appropriate age. And then you need to give the parents health advices, to little games that they can play with their baby to develop the baby's body. And those information are also in the new Road to Health booklet. I must, please remind me to send it to you guys if you don't have it, so you can have it electronically. And this is then also where weight and length will come in, so you can record it there. And then lastly, social or parents. What's the interaction between the parents? Are they bonding, or is she just tolerating this baby? Okay, do they have support? This is very important. Maybe you are the only support. Okay, and that's why you need to build a trust relationship so that you can get information. There are families out there that's completely alone, mothers and their babies, and they're foreigners usually. They don't have neighbors who wants to look after them. They don't have an income, and those people need to be referred to the social worker at the clinic. Again, record keeping, refer. Okay, and that concludes physical assessment of the infant. Thanks, Glenn.